Understanding HTLV. HTLV, or the human T lymphotropic virus. We're going to talk primarily about type 1. There are 4 types so far that have been named or given a number. HIV used to be type 3, but it's no longer type 3. It's in its own group. And there's about 70% similarity between types 1 and 2. And type 4 is different from every other virus that's ever been found. But type 1 is the real problem child, if you want to call it that, because type 1 is the one that's associated with a variety of diseases, and that's the one that we're most concerned about. The others really tend to be asymptomatic or have not been shown to have any disease process associated. So the first one, type 1, was discovered by Gallo in 1980, and it was particularly discovered linked to lymphoid cancer. And 3 years before, Takasugi had identified or characterized adult T-cell leukemia lymphoma as a new disease in Japan. And then when Gallo found this virus associated, a lot of research took off into what this thing was and what it could do. If you can see this, it's a little bit pale, but basically all the white areas have no real association or presence, no endemic presence, no regular ongoing transmission of HTLV1. The pale yellow areas have less than 1% of the population affected, and then the orange areas between 1 and 5%. All the red stars indicate areas where the prevalence of HTLV in the population is more than 5%, in some areas up to in the 30s. So most people with HTLV1 have no disease, but approximately 15 to 20 million were estimated to be infected worldwide in 1993. We're now in 2015 and things have changed. Social interaction has blossomed, and this number is most likely significantly more. It's endemic in many countries, in particular Japan and the Caribbean have had the most challenges with it, have done the most research, and up to 37% prevalence in some areas of Japan, with more Japanese people being affected in the southern areas like Okinawa as opposed to the northern parts of Japan. And in the Caribbean, approximately 5% prevalence. It varies between less than 1% and up to 17% in some areas, but approximately 5%. And then Africa and Melanesia are also affected. So why is this virus important? During the lifetime of people who carry HTLV1, 3 to 5%, 3 to 5 out of every 100 will develop adult T-cell leukemia lymphoma, which is an aggressive cancer. 2% will develop tropical spastic paraparesis or HTLV-associated myelopathy, which is a neurological disorder affecting the spine, the spinal cord and nervous system. And it increases with increasing age. So in Jamaica, in previous studies done, especially in the 1993 study, in those 10 to 19 years, the prevalence was about 1.7%, but that increased to about 9.1% in men. This is for men by the time they became over 70. And in women, it was about 1.9% in that same 10 to 19 age group, increasing to 17.4% over 70. So that's quite a lot. And as we get older, then our risk is higher for a number of reasons. In terms of the virus itself, it's an RNA retrovirus. RNAs are usually messenger proteins, and it uses a particular enzyme called the reverse transcriptase enzyme to change its RNA genetic material to DNA or double-stranded genetic material that it can then insert into our cells into our DNA and use our cells as a machinery to replicate itself and cause disease. And more than replicate itself, it incorporates into the cell machinery and then prevents the cell from functioning normally. It turns off a lot of the regulators. So in some cases, the cells become immortalized. They don't die. And normally, not just us, but each of our component cells has a lifespan. They are created and then they die. But when this is turned off, then the cell becomes practically immortal. And that's where the problem occurs in many of the disorders associated with this virus. So then how do we get it? You have to have an infected T cell. So the white blood cells that fight off infection, some of them are called T cells, some B cells, and the T cells get infected. And this can be in three main ways. Parenteral, meaning through blood transfer, usually through blood transfusion before we did testing. In mother-to-child transmission, so across the placenta in the womb, which is a very low risk, but also primarily in breastfeeding. And that has been shown to be up to 18 to 26% in Jamaican infants between the ages of 4 months and 27 months. And in the Japanese population, the same amount between the ages of 6 months and 24 months. So that's quite high. And sexual transfer, where we find that women are much more susceptible for a lot of reasons that we have not yet identified. And it is 4 times more likely for a woman to get HTLV1 from a man than for a man to get it from a woman, although transfer occurs both ways. But getting HTLV1 through blood transfer is the most highly efficient, and we found that up to 44% of people will have conversion to a positive test within 2 months of exposure to infected blood. And for breastfed infants, for those who are breastfed for less than a year and stop, the transmission rate is about 9%. For those who are breastfed for over a year, when the maternal antibodies are now leaving the circulation, transmission is up to 32%. So the maternal antibodies help to protect the child, but there is still significant risk. And the longer breastfeeding occurs, the more the risk of transmission. So looking at HLV-associated diseases, the things that we try to avoid by trying to prevent transmission, they come in different forms, but you could broadly group them into cancer-type disorders, inflammatory problems, and immune suppression, where the body is no longer able to protect itself against invading organisms or germs. Looking at it a slightly different way, we tend to look at the nerve disorders or neurological disorders. So the TSP ham that we mentioned before affects the nervous system. Very often people will have increasing problems, health-related problems, as they get older with that, and significant loss of function, loss of ability to work. Skin problems, especially in the children, we tend to get infective dermatitis. Those who are infected through breastfeeding or in the womb will have earlier problems, and even though it is rare, there is still some risk of cancer for the children in terms of the adult T-cell leukemia. Well, it's no longer adult at that point, but there are some changes that can occur in children rarely, and that seems to be related to having a higher viral load when they're tested earlier. And then eye problems, which are usually the inflammatory issues, and rheumatologic problems. So a lot of this has to do with immune system dysregulation. The immune system is not regulated normally anymore, and then these problems occur. So if we just take a quick look here, just a small diagram to illustrate that the HLV1 infected cell is quite efficient at crossing the blood-brain barrier, this pink barrier across here. Can you see that? No? Okay, pointer not coming up. But that pink line across the middle is supposed to represent the blood-brain barrier. And that usually keeps out most of our problems. But HTLV1 infected cells are our own natural cells that are meant to cross that barrier to police the internal system. And when they're infected with HTLV1, they carry friends with them. So that sets up chronic inflammation, and damage occurs to the nervous system and the nerve cells, which do not regenerate. So that just gradually gets worse. In terms of adult T-cell leukemia lymphoma, things are slightly different. There is estimated to be a 2.5 to 5% risk over the course of your lifespan if you have HTLV1 up to, call it the age of 70. That's the average lifespan these days. And the annual rate of development among carriers older than 40 years is estimated at 1.5 per 1,000 in men and 0.5 per 1,000 in women. And this is increased in those who are infected earlier in life, those who are elderly, when your immune system is no longer as robust. Males are more at risk of ATL and severe disease if there's a family history of it, which also may link back to earlier acquisition. Increased levels of antibody against the virus somehow also suggest a worse outcome. And tobacco smoking, which is known to be immunosuppressive. So just a little picture of what the skin sometimes looks like with adult T-cell leukemia lymphoma. And that's characterized by involvement of many of your organs, can involve the liver, the kidney, the spleen. It goes everywhere. So you tend to have skin lesions that progressively get worse and are difficult to treat, can have bone breakdown. You can have release of a lot of calcium into the blood from breakdown of bones, and that can cause a lot of problems, including pains, dehydration, gut dysfunction. There are many issues related to this. And the pretty picture on the side is the cloverleaf cells. Those are the characteristic cells that our hematologists will see when they look at the blood under the microscope. And then they'll say, okay, this is likely ATL. Don't worry too much about this slide, just for those who are interested in how it works in a little more detail. But you have multiplication of the HTLV1 and the CD4 T cells, the CD25 T lymphocytes, and they express varying proteins on the external surface, which will then communicate with your body systems to increase the ability to attack and spread throughout the body and stimulate chemicals that will attract more cells to be infected. So it's pretty bad. Just a quick set of pictures just to mention some of the things we've talked about: the skin involvement, the bone involvement, and the blood. So in children, just to show you some pictures, infective dermatitis just looks like really bad eczema. They tend to get infections with certain bacteria like Staph aureus, and it can be very difficult to treat and can be relatively disfiguring for those who have more severe disease. In the adults, they tend to get other problems. So when the immune system is suppressed, and this gentleman unfortunately had scabies that went unrecognized for some time, and with the infection with HTLV1, he was susceptible to a much more rapid progression of his scabies, and we call that crusted scabies or Norwegian scabies. Also strongly related to HTLV1 infection, especially in Jamaica and Japan, is Strongyloides. It's a worm infection or helminthic infection, and here you just see those little purple ovals, the long ones. Those are some worms in the small bowel. So they tend to gather, get comfortable. They found a new home and they multiply, and the heavy worm burden can cause a lot of problems. These are some of the things that HTLV1 comes with for people who develop disease. As we said, 3 to 5% lifetime risk of developing some of these diseases. So it's still relatively rare, but it's happening to quite a number of people. And our goal is really to prevent, because there is no direct cure for HTLV1 infection. There are some drugs that have been tried, even some HIV-associated drugs have been tried with HTLV1 with some limited effect. But we still haven't found a cure. We haven't developed a good vaccine as yet. And so for the most part, we work with prevention for now. So in terms of prevention, blood donor screening helps a lot, because it's not so common that we would randomly screen everybody in the population. We can't afford to do that. So every time you go and donate blood, you get screened for this, because it's transferred in blood very efficiently. And then we always recommend condom use. And there was a big difference in the studies between Japan and Jamaica, where in the Japanese population, condom use was much more common with women compared to the Jamaican population. And they found that that changed the dynamics of how HTLV1 spread. And they were able to see a decline in HTLV1 transmission and prevalence in their population, and a later onset of disease, whereas in Jamaica we tended to see disease earlier, in the 30s and 40s, as opposed to in the 50s in the Japanese population. Hopefully one day we'll get a vaccine, but in the meantime we just need to make every effort to prevent and to screen. But thank you.